Hello everyone, this is Yannis Skalkidis speaking. We're going to speak about evaluation in the healthcare sector. Defining at first evaluation. WHO in 1998 has offered a definition which covers all aspects, and it says that it is the systematic examination and assessment of the features of an initiative and its effects in order to produce information that can be used by those who have an interest in its improvement or effectiveness. I would like to, and we have, that's why in bold the word improvement. The evaluation is not just for the sake of the evaluation, but to enable us to improve the situation. Having said that, I think it would be useful to add two more approaches in defining the concept of evaluation. Spriggett in 2001 has said that the aim of evaluation is to contribute towards solving practical problems in terms of what works and why. Second, that it is about collecting information to inform action, and most of all, it is about learning from experience. Please keep in mind this learning from experience. There is no point to evaluate something without the element of learning. And the other contribution to what is evaluation is coming by Clegg in 2002, who said that good commissioning of evaluation is about creating a context in which evaluation can inform policy. Extremely important and useful for our everyday practices. Apart from the definitions, I would like to contribute to some key aspects regarding evaluation. And the key points in that is the modesty in our expectation, that we should be away from accountability, that there are multi-method approaches and open to complexities and system approaches. We will find all those aspects in our current practices when we evaluate healthcare organizations. Are extremely important to pay attention to those. A fundamental issue in evaluation is whether any reported change can actually be attributed to a specific intervention. How do the outcomes of the intervention compare with any counterfactual situation, the position that would have existed had the intervention not taken place? This is surely true, but also quite complex. In any case, though, we need to work on that and provide scientifically robust answers. On the other hand, it has also been used quite often as an excuse not to accept quite well-documented facts on those grounds. We may never be 100% sure about all causal parameters or the impact of an intervention, but actions have to be taken even under uncertainty. And this is the point where pure science and management have to find a compromising golden balance if we are determined to improve our organizations. So there are some key decision-making steps that can be summarized as purpose and the scope, the design of the evaluation, the selection of indicators, the data gathering methods, the analysis and the interpretation, and of course the presentation of all this process. And now, few words about the models of evaluation and their focuses. There are many. The most important for our case are those that they are listed in these two slides. And of course, there is no need to go through all those types of evaluation, but it's imperative to choose the right type of evaluation in any effort to evaluate how well we are doing. Any carelessness about it most probably will have severe consequences on human lives, suffering, or financial losses for the healthcare organization. And I have put in red the most relevant models, which is the goal-oriented evaluation with a focus on effectiveness, efficiency, and economy of an intervention one, and the other model, which is the decision-oriented evaluation, which has a focus to improve decision-making, which is vital for any healthcare organization. Of course, there are the other models that you can see in the slides. In this, the second slide, just a pay attention only to the goal-free evaluation. It's a really interesting model which can be used in a big organization, because sometimes thinking that we are focusing on a specific goal, we miss the chance to find other interesting results. And but by having a goal-free evaluation, we let the whole space open, and we may find very interesting topics that we haven't thought of. The importance of stakeholders, major stakeholders, at least in evaluation, is extremely important. And this is the reason is because, as you remember in the beginning, we say to inform policy. Who's going to do something about it? The stakeholders. So who are the stakeholders in our case? Funding organization, the diverse groups, very often patients, healthcare professionals, clinicians or non-clinicians, policymakers, organizations from the healthcare industry, and academics and researchers, of course. All of them have a saying in that, and they should be very active in the evaluation. In this slide, you can see that evaluation should be responsive to the needs of different stakeholders, objective, reliable, and generalizable. All characteristics are more than obvious that in terms of their importance. Please pay attention to the first point, though. The diversity of stakeholders should not be slipped unnoticed. Otherwise, we will evaluate, and the otherwise good results will be of no interest to the recipient whom we made the study for. Also, be careful about the consequences of generalizability. Not so much if our evaluation is not generalizable for others, but mostly for those evaluations and their results that we may be keen to adopt from others in our organization, and they may not be applicable. In the next 3 slides, we will see the basic aspects for evaluating interventions. And we're not going to go through the reading, but I'm just saying that the important things are the purpose, the practicality, the process, the contextual factors, extremely important, I would like just to say, by the way, probing, plurality, participation, plausibility, power, and politics. Here you can see the influences to achieve expected outcomes. In red, you can identify maybe the most thorny issue that you will face. The very way you will ask, offer, market, sell, request, or demand from your staff will make the difference. It can be a paradise or a hell, but it will be all yours. So be analytic in designing and systematic and especially patient in applying whatever intervention will be, whatever evaluation of this will be, so that you will pave the way for the desired adoption by the staff. In the next 3 slides, there are listed the key features of a realistic evaluation. And in red are the most, let's say, critical issues for discussion. And the first point is that the intervention will release the potential for change. The potential for change is what you introduce with an intervention, not the intervention per se. This is important to grasp and act based on this. This point says that to you, that you need at your side all those who will realize and implement the new potential, namely your staff. You need them to be active actors and not observers sitting on the side. In this one, you see that in red it says that the context, mechanism, outcome, configuration provides information about what works for whom and under what circumstances. The learning derived from such an approach can therefore be transferable. The only way we can maximize the impact of an intervention is to learn the mechanism of how it worked in the specific situation where it was applied. And in this last slide about the key features of a realistic evaluation, it says that evaluation should adopt a bidirectional teacher-learner relationship. And this is, please keep in mind that that is a key for success. And of course, the effectiveness is expected to be influenced by the ever-changing context, which have been a fact that was mentioned in the previous slide. Just a brief touch on the sleeper effect. There may be a time lag between intervention and the emergence of effects, the so-called sleeper effect. So this effect is so important. It can relieve you from such a frustration, thinking wrongly that nothing works and you have simply messed it up, but this is not the case. And the role of others. An intervention may have no effect at all until all the other necessary conditions are in place, and once they are, this intervention may produce substantial and very rapid change. So the same comment as before, please stay calm and examine in more details all contextual parameters that may have influenced your effort. And something about the mode of adoption of innovations in general. Since we are talking about evaluation of intervention and how they can be perceived and adopted or not adopted by the target population groups, I thought it would be useful and interesting to briefly refer to the mode of adoption. So those figures that you can see in the slide apply also in the health sector, and it is interesting and especially useful for top management of a hospital or any organization to have even a rough idea about where their personnel stand. This information will obviously be quite useful in any attempt to introduce innovations in any organization. And the reason is that you may find that your early adopters, for example, are not at all so many. So you may need to pave the way before you launch an innovative intervention. And now we are coming to a quite complex, depressingly complex, I would say, but on the other hand, absolutely imperative task. What is this? It's an overall, all-inclusive, comprehensive evaluation of a healthcare organization. And in this respect, we have to be frank. This is not at all an easy task, and we should admit that. And we should also not take for granted that it is reasonable, even feasible. Our efforts are flawed, and we cannot claim that we always follow scientifically sound methods. It was always like that, and it will continue to be equally or even increasingly complex, and in a way controversial because of this reason. What we currently do to evaluate our health organization in a comparable way using similar evaluation measures. What are we doing? Standards have been developed, and all modern healthcare facilities are expected to comply with those standards. In most of the cases, but not always, this is done on a voluntary basis. This is nothing else but the accreditation process. So, accreditation. This is the most commonly used evaluation tool in modern times, but it is still a long way to go towards rectifying the many shortcomings of accreditation and to reach to an ideal system for evaluation of healthcare services. At this podcast, we will only touch the basics of accreditation, just to pave the way for a fruitful discussion in the workshop around the issues that matter most the healthcare organization in this domain. The definition that WHO suggested in 2003 about accreditation is that it is a system of external peer review for determining compliance with a set of standards. I would like to stress the notion of peers. We also need just to make a note to differentiate accreditation from licensing. So accreditation, the only I would like to stress out of this slide is the first sentence which says that it aims to raise the quality of health services towards internationally accepted best practices. We will speak later on about the surveyors, how experienced they should be, where the focus should shift away from the structure towards the outcomes and so on. But I would like to stress the following. De facto, accreditation falls under the principles and practices of continuous quality improvement. On the other hand, licensing is somehow the equivalent of quality assurance. It ensures that mandatory safety aspects are in place and is based on minimum standards. And the compliance is taken as a direct response to complaints and adverse events. So the focus on minimum standards as opposed to accreditation, where the focus is to improve the performance of health services beyond the minimal level, is quite substantial, quite important. Also, it is conducted by inspectors trained to inspect the facility's environmental compliance with licensure standards, which is not at all the same with the peers that they are coming to review the achievement of an organization, which happens in accreditation. So, and now we are coming back to the crucial issue of peer review that was mentioned before. Accreditation is a coin with two sides. The one is to guarantee fulfillment of standards. However, the value of the money of this coin is written on the other side. It is where improvements can be made, where advice is offered, even if the standards are met by the organization. In our job, we are labeled as consultant surveyors. You can see the value of consultant, though, is what really counts. And here is where we recruit the peers in the process, because only a peer, namely an active healthcare professional, can grasp relevant issues, enabling him or her to read behind the lines, simply because he or she masters the domain under scrutiny. He's a peer, he's a colleague. So ticking boxes is not the way to go. It is more towards a bureaucratic methodology rather than the needed peer review that WHO has clearly defined and demands in its definition of accreditation. Well, the components of an accreditation system, you can see them listed. A couple of comments. As long as evaluation and improvement is in the interest of everyone, including stakeholders, of course, it goes without saying that stakeholders should be as active as everyone else, not only in the development of accreditation standards, but also in the whole process of implementation of accreditation. Pragmatic and realistic standards is also a key, but this seemingly inflexibility has to take into account, to the extent possible, potential local conditions, the context. And to do that, the competency of peers is coming back on stage. Someone who is not really an active health professional, he's not really a peer, a colleague of the guys that he is surveying, can be a surveyor, but still is not a peer, who is able to see beyond the standards and not fall in the trap of simply ticking boxes, as I said before. So I hope it is clear that the notion of objectivity is somehow distorted in this situation. And just to make things clear and transparent about expectations that we may have about accreditation, we should say right from very clearly, accreditation is not a guarantee of absolute quality, is not a guarantee of absolute safety, is not a guarantee that all risk will be eliminated, is not a guarantee that evidence-based best practice is always provided in the organization. What it is, though, is that it is enacting in the best interest of patients. It is a commitment to minimizing the risk, a commitment to maximizing quality and safety, and it is being a learning organization. So accreditation is not about passing an exam, it's about commitment. Accreditation is not a goal, quality improvement is the goal. Accreditation programs guide performance and influence organizational culture. Efficiency. Health systems need to become less accepting of errors. Poor quality is very expensive, as you know. Legislated solutions are only part of the solution. Minimum standards and licensing or punitive measures are not what accreditation should head to. And there is a growing body of research that supports the value of accreditation. Strong leadership and organizational culture are absolutely important in this effort. So the benefits of an organization due to accreditation is that it is improved quality of care, increased public and consumer confidence, increased efficiency, cost reduction, credibility with insurers, external objective evaluation, and so on. But a good question about the benefits is what evidence is available. But also keep in mind the methodological obstacles for a really good study, scientific study with standardized cases. Let's not forget that all healthcare organizations are radically different from each other. They are at different levels of quality maturity regarding quality and have different QI systems in place. So the specific accreditation system that is an external interventional mechanism may be and usually is substantially different for each organization, making valid comparisons quite difficult. However, against all odds, there are studies that claim that and document the benefits listed in this slide above are real and substantial. So, having said all that, what else do you think is important and urgent to be done in your organization? This is another challenging domain for a lively and fertile discussion in September. Thank you and see you soon.